Hello and good evening, everyone. Welcome to our 75th Blue Hills Virtual Seminar. Blue Hills Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Hills Ethiopia in partnership with Ethiopian Society of Hematology and Oncology. Blue Hills Ethiopia is a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Dr. Yemisrach, a general physician and first aid trainer from Blue Hills Ethiopia. Today, it's a pleasure having Dr. Yemisrach Mengistu here with us to have a presentation on the principles of chemotherapy. So Dr. Yemisrach Mengistu is an assistant professor of clinical oncology at St. Paul Hospital.
Okay, good evening, everybody. As introduced, I am Yemisrach, a clinical oncologist from St. Paul Hospital Millennium Medical College, and it's a great honor for me to present about principles of chemotherapy, because this platform would allow me and my colleagues to reach out to many different health professionals that would change the face of oncology, because the availability of care hasn't been too wide regarding oncology. So you guys having the basic knowledge regarding chemotherapy will aid us and our patients maximally. So while proceeding with today's presentation, the outline would consist of a definition of cancer chemotherapy. We'll see something about the historical background, the classes of chemotherapy, the goals or intents that we give chemotherapy for, how we assess patients pre and post chemotherapy, as well as some misconceptions that the community as well as the patients have regarding chemotherapy, and we'll try to address those via evidences. Please move the slides. Okay. So we'll go to the definition of cancer chemotherapy. So chemotherapy, as the name indicates, is a combination of two words, chemo and therapy. Chemo pertains to chemicals, and therapy means treatment. So the use of any chemical agent to aid or facilitate the treatment of patients is labeled as chemotherapy. So when talking specifically to oncology, we're going to talk about cancer chemotherapy. Otherwise, antibiotics are also chemotherapy if we go by the definition. So cytotoxic chemotherapy refers to the agents whose mechanisms of action cause cell death or prevent cell growth, generally through inhibiting different functions of the cell cycle, which we'll be dealing with after some minutes. So what makes chemotherapy an important pillar of management in oncology is that in most patients, when we find cancer, it may not be a localized disease upon the initial discovery or the presentation, or patients might progress throughout the disease course, mandating the use of chemotherapy. So chemotherapy, like radiotherapy, like other targeted treatments and surgery, is one of the pillars of cancer treatment. The intent is to cure whenever possible, or to alleviate symptoms and control symptoms whenever it's unlikely to cure the stage. So chemotherapy, as mentioned, is the use of any chemical agent to treat. So it's an umbrella of many different treatment options that you see on this diagram. Next slide, please. So as per the diagram, we have the cytotoxic chemotherapy, immunotherapy, hormonal treatment, targeted therapy, or biological treatment. So these all are included under the name chemotherapy. So how was chemotherapy discovered, or how did it came into the world of oncology is quite interesting. So during the Second World War, there were ships that contained nitrogen mustard that were transporting nitrogen mustard. So luckily or unluckily, those were attacked during the war. So that nitrogen mustard containing ship disseminated what it contained. So most of the soldiers were hurt and dead. So what they did was they took the bodies of those soldiers and autopsied it. And upon the autopsy, they discovered those patients had a significant bone marrow suppression, as well as their skin and their mucous membranes were sloughed off. So this led them to think that the use of nitrogen mustard in the treatment of leukemia or lymphoma could lead to a decrement in the cell counts, and that it can be taken into therapeutic purposes. And that's how it started labeling chemotherapy as a treatment agent. So chemotherapy through the century has evolved quite well. As you see, it started in the 1940s by using nitrogen mustard for the treatment of lymphoma, but throughout the years, the treatment has become more patient-centered and targeted to reach where it is now. And currently, we have patient-based treatments or gene-based treatments that are quite fascinating to think about. So how does chemotherapy work? So as I tried to mention during the earlier slides, it works in accordance with the cell cycle. So you all know about the cell cycle. It's the life cycle of a cell where it progresses from preparing its materials and ending up in division of cells or mitosis. So chemotherapy, the different classes work in accordance with the cell cycle using different target areas in the different phases of the cell cycle. So can we proceed a few slides? So we have an image to show. Yes, so I wanted to show you the cell cycle here. So as you know, the cell cycle is largely dominated by the interphase, and we also have the mitosis phase or the M phase. So the interphase comprises of the G1, S, and G2 phases. So the G1 or the growth one, or some call it the gap 1 phase, is a stage where a cell is preparing for its DNA replication. So there is protein synthesis that are required for the DNA replication to occur, and the cell goes a significant growth, preparing it for what's to come. So during the S phase or synthesis phase, it's where the cell synthesizes its DNA, and the G2 phase is a pre-mitotic preparation phase. So it goes with the protein synthesis finalization that would help the cell in undergoing a successful mitosis or replication. So remember this cycle when we proceed to talk about the classes of chemotherapy. Okay, can we go back to where we were? Okay, so the cancer cells, as you know, have quite a replicative potential as compared to the normal cells of our body. So this makes them a better target for chemotherapy drugs. So the difference or the drawbacks with chemotherapy are it's a blanket treatment. It could not differentiate between the normal healthy cells and the cancer cells. So treatment of cancer cells is actually a delicate balance between controlling the disease by killing the cancer cells and sparing of normal tissues or normal cells that would help us lessen the side effects later on. So the other good thing about a chemotherapeutic treatment is that the recovery potential. So normal cells or healthy cells after a chemotherapeutic exposure have the ability to recover from what happened to them after the chemotherapy, while cancer cells, because they are mutated cells, they do not usually recover from the effects of the chemo. So this is why chemotherapy is one of the pillars of oncologic management. So when we proceed to the classes of chemotherapy, we have many different classes of chemotherapy. We have alkylating agents, which are one of the oldest chemotherapeutic agents, like mentioned, the nitrogen mustard. So these are a non-differentiating agent, or they act with the cross-linkage of the DNA, so they arrest mitosis. And with the taxanes, we have paclitaxel, docetaxel. We have topoisomerase inhibitors like topoisomerase topotecan. We have platinum compounds like cisplatin, carboplatin. We have anthracyclines like doxorubicin, antimetabolites like methotrexate, tubulin interactive agents or zinc alkaloids, and some other miscellaneous agents that can't be classified in the above mentioned groups. So as you see here, I don't know if the image is visible for you, but this is the cell cycle we have mentioned earlier, and these are the targets the different classes of chemotherapies act. So some are non-differentiating, while some have a specific target within the cell cycle, as you can see. So with what intent do we give chemotherapy to patients? So we have different intents of giving, or different goals of treatment of cancer patients. So the first is what we call an adjuvant treatment or a supplemental treatment. So the goal of adjuvant treatment is that we have a primary treatment, be it surgery or another, and the intent of giving chemotherapy after that is that it would help us address micrometastasis that haven't been addressed by the primary treatment, or it would help increase the disease-free survival in those patients. So the next is neoadjuvant. So as the name indicates, it is given prior to the planned treatment. So this is given to aid the intended treatment. So it might make tumors resectable, especially when we talk about breast CA, rectal CA. We have this neoadjuvant chemotherapies that would help us convert tumors to resectable, or it might be to preserve some organs. So with the intent of making the primary treatment easier, we give chemotherapies as neoadjuvant. The other is palliative. So as the name indicates, palliative helps in controlling the disease or alleviating the symptoms. And this is usually given when we believe that cure is unlikely in such patients. The other intent is maintenance. So maintenance, we start patients on maintenance chemotherapy when they have completed the intended treatment and they're in remission. We start the maintenance chemotherapy in hoping to prolong the remission after the definitive treatment. So as most of you know or come across, you have seen patients taking 2 or 3 drugs prescribed as chemotherapy. So why isn't a single agent enough, or what is the rationale behind combining chemotherapies? So single agents are can rarely achieve a cure in patients. There are some exceptions for sure, but most of the time it's with combination that we can achieve the likely goal or intent of chemotherapy. So with combination of chemotherapy, we can provide maximal cell kill because many different chemotherapeutic classes could act in different phases of the cell cycle, enhancing the success of treatment. So the other is it provides a broader range of interaction between drugs and tumor cells with the same token mentioned. And the other is it would help prolong the emergence of drug resistance. So combining chemotherapy has been one of the, we can call it a standard practice in oncology. So what principles do we follow in combining chemotherapy is both, or if we're using 2 drugs or 3 drugs, all the drugs must be active as a single agent. They should stand alone as a single agent, being effective in treating that specific malignancy. The other is we should use drugs with different mechanism of action because it is futile to combine drugs with the same mechanism of action. We're just going to enhance toxicity to the patient. The other is we should also use drugs with different mechanisms of resistance. So as you know, cancer cells are quite mutating. So with the started treatment, if we're not targeting them at multiple levels, it's easier for them to develop resistance for a single drug, and this might lead to failure of treatment. So using drugs with different mechanisms of resistance is also one principle to follow while combining chemotherapy. The other is we should use drugs with different side effects. This is not to enhance toxicity on the patients. If one chemotherapy is neurotoxic or nephrotoxic, and the other one that we're combining with the first drug is also nephrotoxic or neurotoxic, then we're enhancing toxicity on the patient, which would lead to drug discontinuation, and this wouldn't be helpful in achieving our target of management. The other is we should always be aware of drug-drug interactions. It's not just with chemotherapy, but with any type of drug prescription. It's always wise to consider any possibility of drug-drug interactions. So we have talked about how chemo works, the classes of chemotherapy, and the mechanisms of combination, or the principles of combination. So what do we do before starting patients on chemotherapy? So we have a patient with malignancy, and we believe that a chemotherapy would be helpful for that patient. So how do we assess patients before starting this specific regimen of chemotherapy? So we have both physical as well as laboratory evaluations of patients before chemo. So the first physical evaluation is an assessment of performance. We call it ECOG, or Eastern Cooperative Oncology Group Performance Assessment Status, or the other is the Karnofsky Performance Status. So both are helpful tools in assessing the performance status. So with ECOG, we have a grading from 0 to 5. 0 is a normal person who is fully active, able to carry on the daily activities without any restriction. We have ECOG 1. There is a physical restriction in strenuous activities, but patient remains ambulatory and can do light housework or office work. ECOG 2, those are ambulatory patients and they're able to self-care, but they might not be able to carry any work activities. Regarding ECOG 3, 4, 5, 3, most patients spends more than 50% of the waking hours confined to a bed or chair, while ECOG 4 is completely disabled, cannot even do self-care activities. ECOG 5 is dead. So ECOG 0 to 2 is regarded as a fit patient or a good performance status patient. So we should consider the performance status of patients prior to initiating any chemotherapeutic treatment. Karnofsky is also similar. The difference is that it is graded from 100 to 0, and we regard patients as fit 70 and above. So the other is lab evaluations. So we have seen how we physically evaluate the performance of patients. The next is lab evaluations. So these are basic lab evaluations. We have the CBC profile, the renal and the liver enzyme evaluations. So the CBC is helpful in checking out if there are any signs of infection in the WBC or any signs of neutropenia, because we'll see later on, chemotherapeutic management is a blanket treatment in most of the cases, so that with targeting rapidly replicating cancer cells, it also targets replicating normal healthy cells of our body, which include the bloodlines. So a baseline neutropenia is a risk factor for patients to develop more neutropenia and sepsis in the later courses of treatment. So we should check that the WBC count, especially the absolute neutrophil count, is within target. So a WBC count of more than, some say 3,500, some say 300, and an absolute neutrophil count of 1,500 is mandatory. before starting treatment. The other we see is the hemoglobin profile. So a patient should have at least a hemoglobin of 10 prior to initiating a chemotherapeutic treatment. And the other is platelet count. At least a platelet of 100,000 is expected from a patient who is a candidate to start chemotherapy. The other is renal and liver enzyme evaluation. So we should have a normal renal and liver enzymes, but this can be difficult to achieve, especially if we have, let's say, extensive metastasis to the liver or any other comorbidities that affect these enzymes. There are ways to adjust based on the creatinine clearance and the liver enzymes, but all in all, it's mandatory to have a normal enzymatic evaluation prior to starting treatment. The other is the routes of chemotherapy treatment. So you might have seen patients taking IV treatment, IM treatment, or pills as chemotherapy. So we have many different routes of administration. These chemotherapeutic drugs, we have oral, IV, both bolus and infusion. We have arterial infusion as seen in TACE or transarterial chemoembolization that we normally use for liver metastasis or HCC. We have subcutaneous for targeted treatments. We have intrathecal that is given via the spine, methotrexate. We have intracavitary, extracorporeal lymphoperfusion, topical. We have many different routes of administration. So the next topic would be the adverse effects of chemotherapy. So we have tried to mention some of them. So the target is a rapidly proliferating cell. So we have some fast-growing healthy cells in our body, including the mucosal membranes, starting from the mouth. We have the bloodlines, and we also have our hair that spend most of their time in the mitotic phase. So this makes them a suitable target to be damaged along with the cancer cells. So patients taking chemotherapy, you might see common side effects from most chemotherapies being mucositis or sores. You might see diarrhea. You might see bone marrow suppression that expresses itself as anemia, neutropenia, thrombocytopenia, or you might see hair fall or hair loss in patients taking chemotherapy. So this is an image that tries to include most of the mentioned side effects. This is not class specific. This is just some common side effects to chemotherapeutic drugs. But when we come to the specific classes of chemotherapy, we have class specific side effects that we would expect. And nausea, vomiting, fatigue, hair loss, these are the mentioned common adverse effects that we see. So side effects, we can see them immediately after the chemotherapy, like within minutes of administration. We can see them within hours or a week of administration, and some could be chronic, that lasts weeks, months to years. So the immediate is related with the infusion, like we might have venous pain, anaphylactic reactions, abnormal taste and smells, while within the short to medium term, we have the nausea, vomiting, the mucositis, the constipation, diarrhea, the tumor lysis syndrome. With long-term or medium to long-term effects, it's usually chronic, and we see them as liver dysfunction. It could be renal toxicity, ototoxicity, cardiac toxicity, infertility, and others. So chronologically coming from the initial slides of our presentation, we have seen how it works, the intent we give the chemotherapy for, the classes, we've seen the side effects, we've seen how to assess patients before chemotherapy. Now we see how to assess patients after we have given them chemotherapy. So this is a post-chemotherapy assessment tool. We call it the RECIST criteria. It's for a solid tumor. It's a response evaluation in solid tumors. So we have different classes of response. We have a complete response, a partial response, a stable disease, and a progressive disease. So As the name indicates, a complete response indicates the disappearance of all lesions and pathologic lymph nodes that we had at the initial stage of the disease, and it's also inclusive of the appearance of no new lesions. So if patients fulfill this all criteria, we call it a complete response. When we come to partial response, it's the decrement of 30% or more of the largest diameter of the lesion with no appearance of any new lesions and no progression of the non-target lesions. The other is as a progressive disease. Progressive, as the name indicates, is an increment in the largest diameter by 20% or more from the baseline, or it could be the progression of non-target lesions or the appearance of new lesions. And if a response does not fulfill the criteria for a partial response or progressive disease, then we label it as a stable disease. So the other issue when it comes to chemotherapy is resistance. So if you have come across cancer patients, you see them taking multiple lines of chemotherapy, or even sometimes during treatment, we might be forced to change the treatment. So what happened in these patients is resistance. So when we define resistance, it's the lack of response from a particular treatment. So it could be a primary resistance, which indicates there hasn't been any response initially or during the very first exposure to the drug. And sometimes secondary resistance is an acquired resistance after an initial response. So this is how we define resistance. The other thing we need to talk about regarding chemotherapy is some misconceptions out there that need to be addressed, because you are the right professionals to provide guidance for cancer patients, and these are the most frequently asked questions even to us from our patients. So I believe this would be a great platform to address those questions. The first one is regarding diet and chemotherapy. So as mentioned earlier, chemotherapy is a difficult or a challenging journey in the treatment of patients. So they have the side effects, they have the psychological trauma from being diagnosed with malignancy. So patients are usually weak, fatigued during the treatment of their malignancies. So diet is quite helpful in helping patients cope with the side effects of treatment. It prevents them to have the weight loss, and it prevents nutritional deficiencies and helps reduce the risk of infections, and also helps with recovery from treatment. So it's quite mandatory for patients to have a nutritious and well-balanced diet. So it should comprise from the major as well as minor food groups, and we should be quite careful in preparing and storing the food, because patients are immunocompromised from their bone marrow suppressions leading to neutropenia. So we should be avoidant of raw or lightly cooked foods. The milks they drink should be boiled or pasteurized. They should not be taking any foods that show signs of mold. And if a food item is kept more than 2 hours at room temperature or more than 3 days in the refrigerator, they should avoid from it. And mucositis would worsen with spicy and hot meals, so that should be avoided. So the other thing that needs to be addressed here is that the use of multivitamin and mineral supplements. So we usually refrain from prescribing such treatments, or we actually make them stop taking them once they are on them. And this is because they contain antioxidant formulas, especially with vitamin C and E. They are highly potent antioxidants. So chemo works with the generation of free radicals or oxidation. So these antioxidants would be scavenging those free radicals, which would later result in the negation of the intended treatment. So we don't recommend taking supplements, and if they have to take the supplements, it's better to get it from food items. but there are some allowed supplements like vitamin D, calciums, multivitamins that would help in recovery of the side effects that we mentioned earlier, but we should refrain from the prescription of especially vitamin C and E containing, as well as any preservatives with antioxidant containing food items. Okay, so the other is regarding the issue of contraception and chemotherapy. So contraception and chemotherapy, before talking about that, we should talk about sexual activity and chemotherapy. So sex is not contraindicated during the course of treatment with chemotherapy, but a multitude of factors affect the occurrence of such phenomenon, and this might be related to patients having nausea and vomiting. It might be resulting from fatigue they have. It might be from mucositis that some of them experience, and some treatments might lead to a decrement in the hormone levels, so patients might have a decreased libido. But all in all, sex is not contraindicated. So if sex is allowed, we should talk about contraceptions. So generally, ovarian failure, especially in women taking a treatment for breast cancer, we see it as a common consequence. So in a study of young survivors of breast cancer, 67% remained premenopausal, and some patients might experience amenorrhea after treatment, which might revert after the discontinuation of the drugs, or some might still be amenorrheic even after the completion of treatment, but this doesn't mean that patients won't be fertile or won't conceive. So during the treatment with chemotherapy or radiation, we don't advise our patients to conceive. And in addition, women with hormonally sensitive cancers like breast cancer, we especially tell them to avoid pregnancy because it complicates the follow-up, because they are hormonally mediated cancers, and we tell them to avoid pregnancy for at least 3 years, which is the peak period of recurrence, or until, if they are on endocrine treatment or hormonal treatment, we encourage them to use contraception until their completion of treatment. So usually with hormonally mediated cancers, we don't prescribe, or we don't encourage patients to use hormonally mediated contraceptions. So generally, non-hormonal method like a barrier or a copper IUD is given as a contraceptive option. But there are some patients who are unlikely to accept those options. So for those patients, we can provide progestin only method. It could be the pill, injection, or implant, but still we should provide those contraceptive options. The other is sun exposure and chemotherapy. So I had a patient who told me that until she completed her chemotherapy, because her treating physician told her about the risks of sunlight with chemotherapy, she was isolated from all her family members. She stayed in a quite dark room, and she did not see sunlight for months. And they would put the food on her door. She would pick it up, eat, return the plates. She did not see sunlight for, I think, 6 to 9 months, and this was because of what she felt that patients on chemotherapy should not be exposed to light. But this is not true. This is a myth or misconception, and as you know, sun exposure is benefiting to our health. It improves mood, and it also is a good supplement of vitamin D, but some chemotherapeutic agents might increase our chance of sunburn, or this might cause a drug-induced photosensitivity. So a direct exposure to sunlight might not be advocated, but we can still allow patients to have sunlight exposure with the use of sun protective clothing and sunscreen, and they would benefit from avoiding sunlight after 10 a.m. to 4 p.m. This is actually a general recommendation for everybody, and upon exposure to direct sunlight, it's better to use protection like sun protective clothing or sunscreen. The other is the issue with comorbidities in chemotherapy. So as you know, cancer is usually the disease of the old, even if the epidemiology is changing these days. So with increasing age, there comes the risk of comorbidities. So with an aging population, we see many comorbidities in our patients. So this affects the general management of the patient. It might be with the diagnosis, the treatment, or the outcomes of this particular population of patients. So there are many reasons patients have cancer along with their chronic conditions. It might be from shared risk factors like smoking, obesity, diabetes, or others which are a mutual risk factor. It could be from lack of exercise, poor diet, or others. So this is a diagram that shows the cause interlinkage between comorbidity and malignancy. So from the study studied in the US with people who have comorbidities and malignancies, they noticed that the patients are less likely to receive curative treatment for their cancer, and this has been reported in different settings. So we see patients with asthma, we see patients with RBI infection, we see patients with diabetes, hypertension, and some of them with the diagnosis of their malignancy discontinue their medications and they come to us. So the take-home point in these patients is that their comorbidities might be the first to kill them from the malignancy, because as you know, these comorbidities are quite multisystemic, so the effects exerted from discontinuation of the drug might be devastating. So we should always encourage patients to adhere to their medications and optimize their disease control. If it is diabetes, we should tell them to optimize their glucose control, their BP control, their dyslipidemic, if they are dyslipidemic, to maintain a good lipid profile, and others. And the other is the chemo choices should be tailored to avoid drug-drug interactions, minimize pill loads, and decrease toxicities, because adherence is quite an issue with their comorbidity medications or with chemotherapy from pill load and toxicities. The other is we should improve the integration and coordination of care. So the other factor that has been seen to prevent patients from taking their medications is that they are sent here and there to optimize their control of comorbidity, so they lose interest in the middle and disappear from care. The other is we should be careful in preventing the occurrence of new comorbidities from the systemic treatment of choice that we have for the malignancy, so that patients won't be frustrated and disappear from the care that they need to have. And this is my presentation. Thank you for your time. If you have any questions, you can provide them on the chat box.
So I can read the first question. So it's by Nathaniel. So he said, does chemo have a permanent effect on brain activity, like neuron damage? Is the first.
Okay. So thank you for the question. So as we have mentioned earlier, different classes of chemotherapy have different effects based on the cycle of cell they act upon. So neurotoxicity or neuronal damage is one of the side effects of chemotherapy, like taxanes, and there are also some other chemotherapeutic drugs that are present with neurotoxicity, and their effects are enhanced by the presence of increased age, other comorbidities. For example, patient might have had a baseline neuronal damage or neuropathies from comorbidities like hypertension, diabetes, or others, and this enhance the neurotoxicity of the chemotherapeutic drugs that we prescribe, and some might disappear after treatment with follow-up, some might persist depending on the presence of other confounding factors in the patient.
Okay, thank you. So another question is, if a pregnant woman receives a chemotherapy, will the baby be exposed to miscarriage or prematurity?
Okay, so regarding pregnancy and chemotherapy, as you know, the first trimester, especially the first 8 weeks are the time for organogenesis, so exposure to chemotherapy during this age is quite detrimental. So we do not prescribe chemotherapy for patients who are in their first trimester of pregnancy. Regarding the second trimester, it's a relatively safer period for any type of management we have, be it surgery or chemotherapy. It's regarded as a relatively safer stage. And with the third trimester, it's also possible to continue the chemotherapy that we have started during the second trimester, but we should be able to stop before 34 to 35 weeks to allow for an uncomplicated delivery. So we should be able to select the chemotherapy as well as make sure that the timing that we start treatment for these patients is in accordance with the standard.
Okay, thank you very much, doctor. So can chemo cause mutation in cells which might turn into other types of cancers?
Yes. Yes, so that is true. Some chemotherapeutic agents, especially alkylating agents that are given during childhood period or early adulthood, could predispose a patient to develop secondary malignancies later in life. So this is a known and studied phenomenon. Agents like cyclophosphamide, for example, could be given for treatment of one malignancy, and later in life they might be acting as a risk factor for a patient to develop lymphomas, leukemias later in life. So it is possible, yes.
Okay. Thank you very much. So the next question is by Dr. Malit. It says, is sex advisable for patients who took chemotherapy for the first 72 hours or maybe 1 week?
So with that question, sex is not contraindicated, but the presence of chemotherapy in vaginal fluid or semen has been seen with some agents. So it is allowed, but with the use of protection. So if a patient is up for it to have sex within the first 1 week after the administration of chemo, it's advised to use a barrier method with the partner, because some were seen to be passing via the vaginal fluid or semen. So it's allowed, but with protection for the first 7 days after administration.
Okay. So another question is, can you explain on tumor lysis syndrome? And thank you.
Okay, so tumor lysis syndrome is especially a noted phenomenon in some lymphomas. So what happens is that there is a tumor bulk, and while we're trying to address that tumor bulk, especially with the first cycle of chemotherapy, there would be a response from the chemotherapy by the tumor cells, and that would result in a metabolic mishap within the cell. So patients present with the derangement of their vital signs, they have derangement in their metabolic profiles, they might go into arrhythmias, and they might succumb to death, but this is all from a drastic response from very sensitive tumor cells to the chemotherapy drugs that we use. And there are some techniques to alleviate or decrease the occurrence of tumor lysis syndrome. So there would be an increased uric acid production, hyperkalemia, hypocalcemia, that would result in the derangement of the cardiac conduction activities and others. So that's what we mean by tumor lysis syndrome.
Okay, thank you very much, doctor. So the other question is, could you mention some drugs given with chemotherapy to prevent the side effects?
Okay, so we have seen the side effects of chemotherapy. So with the administration of chemotherapy, we have pre-medications that we provide for patients. These medications like dexamethasone and ondansetron, metoclopramide, this would help in decreasing the occurrence of nausea and vomiting during the administration of the chemo, and with their emetic potential. So different chemotherapeutic agents have a different emetic potential. So with their specific emetic potential, there are group of drugs, combination of drugs that we can allow the patients to take to alleviate the symptoms. And also upon discharge, we have what we call a delayed MSS, delayed nausea and vomiting, after patients have completed treatment and went home. So we give or we discharge them with PO medications to help them cope up with these side effects.
Okay, doctor. So another question by Kadus is, what can we advise patient with depressed appetite for food while taking chemotherapy?
Okay, so anorexia is a noted side effect with the administration of chemo. So we have both medication as well as psychological support for the patient. So with chemotherapy, patients first must be aware that during the first week of treatment, they might experience such effects. So the first one would be telling the patient that these are expected side effects. And after that, there are some techniques that we help patients overcome their anorexia. The first one is they should be able to eat what they like with frequent meals. They should not eat in bulk at once. They should divide the meals that they're going to have, and they should ambulate. They should stay away from the area of food preparation. And there are also some medications that would help the patients have a maintained appetite, the easiest one being dexamethasone. We can also provide with progesterone, like megestrol acetate, that would help alleviate anorexia in such patients.
Okay, thank you very much. So the other question is, in our country, the nurses preparing chemotherapy without PPE. So what is the suggested side effect towards healthcare professionals that are preparing chemotherapy, and how to overcome it?
PPE is mandatory for health professionals that are preparing chemotherapy. So as you know, there are many different ways a drug can reach us. It's not just with the actual contact of the drug to our body, but there are some inhalational effects from some chemotherapeutic drugs, and we can't avoid skin-to-skin contact sometimes. So it's actually quite difficult for someone to be preparing chemotherapy without the actual protective gear. I don't think that's wise, and I encourage you to demand for a PPE if you are preparing the chemotherapy.
Okay. So the next question is, what are the criteria to discontinue chemotherapy regarding the adverse effects of the medications?
Okay, so that's a good question. Regarding adverse effects, we have adverse effect grading criteria. So whether it's nephrotoxicity, neurotoxicity, skin toxicities, what have you, we have different classes or grades of classifying those adverse effects. So grade 1, grade 2, grade 3, some up to 5. So with mild, moderate, and severe degrees of toxicity. So generally with mild toxicities, we should continue the medications without any dose adjustment or change of regimen. With moderate, we might be pushed to decrease the dosage of chemotherapy, but with severe side effects or adverse effects of chemotherapy, we might be obliged to change the treatment regimen to a more tolerable one.
So what is your suggestion on the management of post-chemotherapy peripheral neuropathy?
So post-chemotherapy peripheral neuropathy is a known entity after chemotherapy of some chemotherapeutic agents. So as mentioned before, it depends on the grading of the neuropathy. So in the presence of other comorbidities that might predispose a patient into having the enhanced effect of neuropathy from the treatment. So there are many different ways of management. Most of the peripheral neuropathies post-chemo would resolve with time, but some might persist, and we have a medication, we have a medical treatment for those persisting post-chemo neuropathic peripheral neuropathies.
Okay, thank you very much, doctor. So on behalf of Blue Hills Ethiopia and all our participants, we thank you for taking the time to present on our platform. It was very interesting and understandable presentation. And we hope to have you in the future as well with other topics. We also would love to thank the Ethiopian Society of Hematology and Oncology for the collaboration on our virtual seminars. So, Dr. Yemisrach, if you have any last remarks you want to add, let me give you the chance one more time.
Thank you for the interactive discussion. Thank you for the questions and thank you for your attention. But from today's session, I really hope you can take home about the misconceptions that most of the people have, because I believe you are the right professionals to answer those questions and to address them. And I really do hope you keep this in your hearts and apply it in your daily practices if ever such a patient presents to you. And thank you for your time.
Thank you very much, doctor, and good night.
Good night.